Hello, welcome to your lecture on seizures. This is one is a little.
So we're going to first look at partial seizures, which means that they have an onset in part of the brain. Other terms that you may have seen used or that people still may be using are localization related or focal seizures. Partial seizures are divided into two main types, and they depend on whether or not consciousness is fully preserved. During simple partial seizures, consciousness is preserved. The patient is alert, they can respond to questions or commands, and they can remember what occurred during the seizure. If you have a complex partial seizure, then consciousness is altered or lost. The ability to pay attention or respond to questions or commands is impaired or lost. Often there's no memory of what happened during all or part of the complex partial seizure. So the distinction between simple and complex partial seizure is critical because activities such as driving and operating dangerous machinery could be restricted in patients with uncontrolled complex partial seizures. Restrictions for people with only simple partial seizures depend on the specific seizure manifestations. Sorry, it's hard to say seizure over and over. Try to say it fast 3 times and you'll see what I mean. For driving, regulations are in a particular state, and I covered that in the last lecture on Kentucky. Generalized seizures ultimately involve motor activity on both sides of the body and can be difficult to distinguish from primary generalized seizures. Still talking about simple partial seizures. They have a diverse range of different things that can happen, so that makes them kind of tough sometimes. You can have paresthesia or tingling in the fifth finger spreading to the forearm. That could be a seizure, that could be a migraine, that could be a TIA. Sudden abdominal discomfort could be produced by something GI, or it could be a seizure arising from brain structures. When those kinds of things happen in isolation, then it's really hard to even tell that they're a seizure. So they're missed lots of times by the patient as well as the healthcare provider. Motor seizures alter muscle activity. Localized tonic posturing, which is stiffening, or clonic movements such as twitching or jerking can occur. Abnormal movements can be restricted to one body part or involve gradual spread to other areas on the same side of the body, and that's called a Jacksonian seizure or a Jacksonian march. On both sides of the body with loss of consciousness. When you have loss of consciousness, that can be a secondarily generalized seizure. Epileptic discharges that occur in the sensory cortex can produce sensory seizures. So they can manifest as hallucinations or illusions, or a sensation that something's there that's not. Hallucinations can remain restricted to one area, or they can spread to other areas and involve like your entire upper extremity or entire side. Hallucinations and illusions can also involve sensory modality, including touch, which like pins and needles or electrical shocks, smell or taste, and it's usually something very unpleasant. They can have vision, flashing lights. They can have a buzzing sound in their ear. So there are lots of things that these simple partial seizures can cause when it comes to motor signs. Autonomic seizures are common, and they invoke changes such as altered heart rate or breathing rate, sweating. Psychic seizures are probably the one that would be kind of hard to figure out as well. People think, feel, and experience things. Patient can report like a dreamy state, somewhere between being awake and being unconscious. Psychic seizures can alter language function, perception, or memory. They can also evoke spontaneous emotions such as fear, anxiety, or depression, alter perceptions of time, and feel like time is slowing down. A deja vu is actually one of these seizures. People can feel like that new experiences are familiar, or that things that they have been doing that are very familiar feel very foreign to them. They can have depersonalization, which is feeling not yourself. So there are lots of ways that these partial seizures can kind of exhibit themselves. Okay, with complex partial seizures, they're often associated with impairment of consciousness. A common misunderstanding is that this requires the seizure to spread to both sides of the brain. The majority of complex partial seizures do originate in the temporal lobe, and they can affect consciousness while still remaining focal. During complex partial seizures, the patient tends to stare off, and this is accompanied by an impaired responsiveness, cognitive function, and recall. Although there can be some degree of responsiveness, automatic movements are common, involve the mouth like lip smacking, chewing, swallowing. They can involve the upper extremities of like fumbling and picking. There can be vocalizations. There could be grunts, repeating a phrase. Sorry, or more dramatic things like the patient could start screaming. So complex partial seizures usually last from 15 seconds to somewhere around 3 minutes. And then after the seizure, they're going to have postictal confusion. That's very common. That usually lasts for another 15 minutes or so. And they may have some fatigue afterwards, and that can sometimes persist for several hours. Okay, to make this even a little bit more complicated is that the partial seizures can actually progress to generalized seizures, and that they'll have some tonic-clonic activity. So once a partial seizure, which is part of the brain, and that's where you get your name, secondarily generalizes, then it's generally impossible to differentiate between primary generalized seizure. The EEG and the neuroexam, especially post-ictally, as well as CT or MRI, can help distinguish those seizure types. So it's not going to be something that you're going to be able to tease out with a history. You're definitely going to have to refer to figure out this. In secondarily generalized seizures, patients can recall an aura sometimes prior to having the activity. Witnesses can usually observe that a simple partial or complex partial seizure prior to the generalization, so they may do something before they start jerking. They may kind of phase out, be absent, and then they may do the lip smacking or something like that, and then it may continue to progress. In addition, following a secondarily generalized seizure, the patient will usually have some focal weakness, and that's called Todd's paralysis. And it's going to be on the side contralateral to the seizure onset. Okay, looking at generalized. Generalized means that it's going to affect both sides of the cerebral hemisphere, and that's from the very beginning of the seizure. So it's different than starting partial and then going to a secondary generalized. This starts generalized immediately. They do produce loss of consciousness, and that can be very, very brief, like an absence seizure, or it can be for longer periods of time. And they're subcategorized into these major types: absence, myoclonic, atonic, tonic, and then tonic-clonic. So let's talk first about the absent seizures. Petit mal is another thing that I've probably heard for a long time about, another name for these seizures. They are brief episodes. They can last anywhere from 3 to 20 seconds. They can be staring, and there's usually impairment of awareness and responsiveness. There's no warning, so there's no kind of taste or aura or anything like that before the seizure. And immediately afterward, the person is alert and attentive. So you can imagine how, if this lasts for 3 seconds, how easy it would be to continue to miss. The lack of postictal period is the key feature that allows you to distinguish between absence and partial complex seizures. If the duration is more than 10 seconds, then they also have some accompanying motor phenomena such as eye blinks, mouth or hand movements, changes in muscle tone. They usually begin between the ages of 4 and 14, and they usually resolve by age 18. Absence seizures are often provoked by hyperventilation, and that's one of the ways that they can kind of reproduce it when they go in to get their EEG, is they can have them hyperventilate, and lots of times it'll reproduce the seizure. It actually, when they do the EEG, it has kind of its own signature for absence seizures, so they can pick that out. These children have normal development and normal intelligence, and it's usually resolved by the age of 18. Myoclonic is another type of generalized seizure that may also be missed based on how quick it is. They usually involve brief shock-like jerks of muscle or groups of muscles. It can occur in healthy people, like when you are falling asleep. Do you ever jerk awake? Well, that's a normal response, but that would be what also like what a seizure would be like. Pathologic myoclonus can result from epileptic or non-epileptic causes. Epileptic myoclonus usually causes bilateral synchronous jerks, and they most often affect the neck, shoulders, upper arms, body, and upper legs. Consciousness does not usually seem to be impaired, although it's really difficult to verify because the duration can be less than a second. And when you really start to notice it, if several occur in a succession, and if they do, then it's then termed a clonic seizure, and that can be associated with altered awareness. So the EEG will show specifically for this type of seizure as well, and they actually occur in a variety of the epilepsy syndromes, and sometimes they're seen as part of a progressive degenerative condition, but for the most part, they do stand alone, and they are very, very short in duration. Tonic and atonic seizures are common in people with other neurologic abnormalities in addition to epilepsy. In contrast to partial motor seizures, tonic seizures are generalized, involving bilateral muscles in a symmetric or nearly symmetric manner. They are characterized by flexion at the waist and neck, abduction and flexion or extension of the upper extremities, and flexion or extension of the lower extremities. They typically occur during sleep, and they typically last anywhere from 2 to 20 seconds. And you can also pick these out on EEG as well. Atonic seizures consist of a sudden loss of postural tone, also often resulting in falls, or maybe just head nods or jaw drops. It depends on how severe the seizure is. Consciousness is usually impaired, and you can have significant injury from this. Obviously, if someone's driving and they have a drop seizure or go out completely, you can imagine what kind of issues that would cause. Duration is usually several seconds. It's rarely more than a minute. Generalized tonic-clonic seizures, this is probably the one that we have heard most about, especially as nurses. These are your grand mal seizures. They can cause loss of consciousness associated with initial tonic phase of stiffening, and the patients usually fall, they cry out sometimes, and that's caused by the air forced through the contracted vocal cords. Legs are usually extended, arms may be extended, flexed, or each in succession. The subsequent clonic phase consists of jerking of the extremities, which gradually shows before stopping. Tonic-clonic seizures usually last anywhere from 30 to 120 seconds. There can be drooling or foaming resulting from lack of swallowing and excessive salivation. There can be biting of the tongue, cheek, or lips. There can be bleeding. There can be a bladder or bowel incontinence. There's post-ictal lethargy and confusion that can last minutes up to hours, and they can also get very agitated after that. The EEG does show some generalized polyspikes. Uh, these are usually obscured by a muscle artifact. What causes seizures? And you know that epilepsy is several seizures. Depends on the age group. Really, infancy and childhood, they can be prenatal or birth injury, inborn era of metabolism, congenital malformation, childhood and adolescence, you're looking at idiopathic or genetic syndrome, a CNS infection, or trauma. With adolescents and young adult first onset seizures, you're going to think about different things. You're going to think head trauma or maybe drug intoxication and withdrawal. With older adult, you're going to think about a stroke. You're going to think about brain tumor. And again, this can happen from mets to the brain from some other cancers. So always consider that. Acute metabolic disturbances, and then neurodegenerative things like Alzheimer's disease and that sort of thing. So not very common in this age group unless there's some type of really underlying cause for that. So if you have a patient that comes in and says that they had a seizure, you have to kind of ask a lot of questions and figure out what caused the seizure, etc. So the initial evaluation after one seizure, you need to determine whether it was actually a seizure or the patient experienced some other transient event. And this would be very difficult in your older person, trying to figure out if they're having a TIA or if they did have a seizure. But your neuroimaging is going to help with that and help you make some determinations. You want to look for evidence of partial onset. You want to search for evidence of underlying central nervous system dysfunction. Look for systemic or metabolic disorders that could have precipitated the seizure. You want to try to classify the seizure if you can. You want to determine what diagnostic studies are appropriate and determine whether drug therapy should be instituted and if so, with what agent. And we talked about this before. I would always refer with a first seizure. If you're trying to figure out, is this a TIA or did they actually have a seizure? Especially if nobody was there to witness it, then it's a little bit more difficult, and you probably would want to start with some type of neuroimaging, and then if that was okay, then you kind of start working from more of a seizure standpoint, but definitely go ahead and refer regardless. This evaluation of a first seizure, this may be a little bit of a repeat from your first lecture, and I'm sorry about that. Oftentimes the patient comes in and they're really not going to remember the events surrounding the seizure. If you have someone else there, can get a description from relatives, friends, those sorts of things, that makes a big difference. Our observers can report behavior consistent with a complex partial seizure immediately preceding a convulsion. In other cases, the patient may recall localized motor activity suggesting a simple partial motor seizure before losing consciousness. At times, the only evidence of a partial onset can be a brief subjective event consistent with an aura. In this case, it's going to be really important to determine whether the identical aura has occurred before. The examination of the patient who's experienced a seizure is often most revealing when conducted as soon after the seizure as possible. Should be frequently repeated to determine whether or not any observed deficits are transient. So, you definitely want to do a really good neural exam and see if anything is still showing up. Post-ictal weakness, aphasia, sensory dysfunction provide powerful information about whether or not it's localized. Upper neuron signs are briefly present post-ictally, so they may have Babinski or something like that that shows up very quickly after the seizure but then goes away. Signs which are not transient but can indicate a pre-existing structural lesion or new condition can lead to the diagnosis of acute symptomatic seizure, and that's seizure resulting from a new brain insult. So that doesn't necessarily imply the existence of epilepsy, although it could develop later based on the other things that are happening in the brain. The general physical exam is most useful when it uncovers evidence of a precipitant for an acute symptomatic seizure, such as meningitis or genetic predisposition to seizures. That's when it's going to be most valuable for you. There are quite a few things that can cause a seizure. Metabolic electrolyte imbalances, stimulants, withdrawal, substance abuse, sleep deprivation, if they're on an AED already, an anti-epileptic drug, and they're not taking their medication or have reduced it, then that can precipitate it. Hormonal variations, stress, fevers, concussions, head injuries. That's why there is a lot of debate about whether or not to work up a first seizure, because there's so many things that can cause it. So whether or not to treat a first seizure is controversial. Within the 5 years after a single unprovoked seizure, anywhere from 16 to 62% of patients are going to have another seizure. That's a pretty wide gap there. Recurrences are more likely if there's been an earlier neurologic injury sufficient enough to cause seizures. If when you did your MRI you noticed some structural abnormalities, if there is a family history of epilepsy, all of those things make it much more likely that the patient's going to have a second seizure later. Most studies also suggest that partial seizures are more likely to recur than primarily generalized tonic-clonic seizures. Now, treatment is going to reduce the chance of that happening by at least 50%, but it doesn't eliminate completely the risk of a second seizure. So, making the decision whether to treat and to give medications is always an individual decision, and probably should be made between the patient and the neurologist. Most of the time, we're not going to be choosing these drugs, but they're a little bit like the SSRIs that we talked about, in that as long as you pick the right one, um, they're all pretty good. And so, how you make the decision is cost, adverse effects, those kinds of things. So you decide whether the patient's seizure are partial or generalized. That's the first thing you have to do, because some medications are for partial and some are for generalized. Some of them are for both. Um, the drug of choice has to have the ability to stop seizures and have the lowest likelihood of adverse effects. So you could try one drug and maybe it's not going to work, but the next drug will. There's not a lot of difference in how well they work, but there is differences in the side effect profile, and also there's quite a bit of difference in cost. Most patients can be managed on one medication. Again, your neurologist is going to be the one to start these. They will usually give a drug to a max dose before they try an alternative drug or before they try any type of two-drug combination. And there is a therapeutic range, but remember that's only a guideline. So if you can get the patient's seizures to stop well below the therapeutic guidelines or therapeutic range, then that's what you want to go with. You don't want to take them up to a therapeutic range when their seizures will be controlled on much less medication. So I think that's one of the major things that's a lot different than what I learned in undergrad. So choosing your drugs, hopefully you won't be, but the big thing that could probably happen is that your patient goes to the neurologist and they start them on a brand new medication that they can't afford. They give them 3 months of samples. The patient is very well controlled on this medications, has minimal side effects, and they write them a prescription for it, and then of course the patient can never afford to get it. So there you are. So there may be times when you do have to change medications, or at least consult with a neurologist about the best medication, and probably most of the time looking at the choice of the AED that they have selected. You'll be able to tell if the patient is having partial or generalized seizures at that point. So choosing a drug, they're basically classified as either broad spectrum, kind of like an antibiotic, or more narrow or partial agents. Broad spectrum agents are useful usually in the treatment of both primary generalized seizures and partial seizures. Partial agents are used for the treatment of partial onset seizures, and usually are not used in primary generalized seizures. and they can actually potentially exacerbate some seizure types. So it does take a lot of knowledge to pick out the medication. Dilantin and Tegretol are some old ones, but they can sometimes be used for primary generalized tonic-clonic seizures as well. And there's also some new medications coming out. Somebody mentioned a drug, I think it was Keppra, which is a brand new one, probably one of the most expensive ones, but also probably one of the better ones. So in primary care, it's basically knowing which medications they're on, what their seizure, what type of seizure it is, and then maintaining them on those particular medications and knowing the side effects. And then, of course, being able to talk about them about birth control and those kinds of things. So I hope this is way more than you ever wanted to know about seizures.